name is Karen Anderson Oliver. I've had lots of experience helping a variety of healthcare organizations improve their services on mental health and substance use disorders. As we'll soon talk about, telehealth would be a great way to deliver SBIRT, so I'm glad you've joined us for this video.
Hi, my name is Rich Brown. I've helped many primary care settings implement and improve their SBIRT programs. In a previous project, I witnessed firsthand the effectiveness of telehealth in delivering SBIRT, so I'm glad for the opportunity to spread the word about this.
In this video, we'll talk about how telehealth can strengthen your SBIRT program, how to do it, and how to make sure you're doing it well. Towards the end of the video, we'll recommend some additional learning resources. Before we delve into our agenda, we'll provide some introductory information on what telehealth is and how rapidly it's growing. According to the U.S. Health Resources and Services Administration, HRSA, telehealth is the use of various electronic technologies to support a variety of important healthcare processes. Of course, in this video, we'll focus on clinical healthcare. Several technologies fall under the umbrella of telehealth, and we'll focus especially on video conferencing and telephone.
Enthusiasm for telehealth has been building for several years. This graph compares telehealth service delivery by 4 major national telehealth companies over the first 13 weeks in 2019 versus the first 13 weeks in 2020. On the x-axis is the week number during the first 13 weeks of 2019 and 2020, approximately January through March. The y-axis on the left shows the number of telehealth encounters that took place during those weeks. The height of the light blue bars shows the number of telehealth encounters during each of the first 13 weeks of 2019. The height of the dark blue bars shows the number of services delivered during the first 13 weeks of 2020. If you look at the bars for week 1, you can see that there was a substantial year-over-year increase in telehealth encounters from 2019 to 2020, well before known community spread of the novel coronavirus. After community spread was recognized, and after CMS liberalized reimbursement, telehealth encounters accelerated rapidly. The solid black line shows the substantial year-over-year percentage increases in telehealth encounters during each week and the accelerated increase starting at week 11. The dotted black line shows the simultaneous substantial drop in emergency room visits.
Many experts quoted in various news articles predict that telehealth will continue to expand, especially for behavioral health services, most of which require only conversations, not physical examinations or diagnostic tests. So could SBIRT be delivered by telehealth? Could telehealth help us reach more patients with SBIRT? Could telehealth make SBIRT more effective? We believe the answer is yes. So now we'll focus on how telehealth can strengthen SBIRT programs and make sure SBIRT continues as more care is done virtually.
When we talk about strengthening SBIRT programs, what we really mean is expanding the program's impact. There are 2 ways to expand SBIRT program impact: increase reach, the number of patients the program serves, and bolster effectiveness, the program's success in reducing patients' drinking and drug use.
First, let's consider what we know about the effectiveness of SBIRT as delivered by telehealth. The authors of this article, published in September 2020, conducted a review of randomized control trials of preventive counseling delivered by telehealth versus face-to-face, telephone, or written materials. They found only 13 such studies published in the peer-reviewed scientific literature. In 2 of those studies, telehealth was compared to 2 other modalities, so those 13 studies include 15 comparisons.
This slide summarizes what the authors found. Each square represents one of the 15 comparisons. For each square, its row shows whether telehealth was compared to face-to-face services, telephone services, or written materials. The column of each square shows the topic: alcohol, obesity, physical activity, or smoking. The color of the square indicates the result of the comparison, whether telehealth performed better in green, about the same in yellow, or worse in red.
You can see that in the top row, showing the comparisons with face-to-face services, telehealth did better in 4 out of the 5 comparisons. In the second row, telehealth did better than phone in 2 of the 6 comparisons, and about the same in 4 of the 6 comparisons, including the 3 comparisons on alcohol. In the third row, telehealth did better than written materials in 3 out of the 4 comparisons. So according to the best available research to date, preventive counseling does seem effective when delivered by telehealth.
We believe that not only is telehealth an effective vehicle for SBIRT, but it would strengthen SBIRT program impact. Many patients prefer to minimize visits to healthcare settings. For some, getting dressed is a hassle. For some, transportation is inconvenient and difficult to arrange. Telehealth can help address these inequities in access to care. The challenge is even greater if children or other dependents need supervision at home or must come along. And then there's the usual waiting time. Many patients would participate in initial SBIRT sessions and in more SBIRT follow-up sessions if they could do so in the comfort and convenience of their own homes.
Fortunately, most American adults, including disadvantaged minorities, people with low incomes, non-high school graduates, and the elderly, have access to the internet, which also gives them access to telehealth platforms. While, of course, this is not fully inclusive of all underserved populations, such as the homeless at times, but many disadvantaged groups do have internet access for telehealth.
Patients who don't have internet access can participate in SBIRT by phone. Since telehealth would allow SBIRT to reach more patients and increase the number of follow-up sessions, it would likely increase the reach and effectiveness of SBIRT programs.
There are a couple of potential concerns about delivering SBIRT by telehealth. One potential concern is actually not a concern at all. There's a myth that telehealth encounters take more time than face-to-face encounters. In reality, the same strategies that healthcare professionals use to stick to their busy schedules of face-to-face visits can be used to make telehealth visits equally time efficient.
Another potential concern, confidentiality, is very important, especially for patients who live in crowded households. Since SBIRT covers sensitive ground, it's important that patients have privacy during their SBIRT sessions. For patients who cannot find privacy outside your healthcare setting, SBIRT might have to await a face-to-face visit.
We would also like to note the characteristics of telehealth that are well suited to the delivery of trauma-informed care and highlight an article that illustrates how telehealth visits can be trauma-informed. This article by Gerber et al. Provides a table of trauma-informed telehealth strategies based on the SAMHSA trauma-informed care principles. These include emphasizing safety through confirming privacy and emphasizing choice by giving patients the options of telehealth or in-person delivery. We've talked about how telehealth can augment SBIRT delivery. Now let's talk about how to do it.
We're going to talk about 9 different options for delivering SBIRT by telehealth. One set of options involves delivering the initial session of SBIRT face-to-face in a healthcare setting, and then delivering follow-up sessions by telehealth. A second set of options involves adding the first SBIRT session onto a telehealth visit made for another reason, and delivering all follow-up by telehealth. A third set of options involves outreaching to patients to deliver SBIRT by telehealth completely separate from any other face-to-face or telehealth visit.
For each of these 3 options, There are 3 variations based on who will deliver SBIRT. One variation is that primary care providers, or PCPs, will deliver SBIRT. A second option is that all SBIRT sessions will be conducted by another staff person who we'll refer to as an SBIRT interventionalist. A third option is that PCPs will deliver the initial SBIRT and interventionalists will do all the follow-up sessions. Each of these options for using telehealth to deliver SBIRT brings distinct advantages and disadvantages.
If your PCPs will deliver the first session of SBIRT, either face-to-face or by telehealth, they'll find it easy to make a transition to SBIRT and visits for other purposes. If your PCPs do SBIRT via telehealth outreach, they may be more successful than other staff in engaging patients.
Having separate interventionalists conducting SBIRT sessions can conserve provider time and allow for longer SBIRT sessions. If those initial sessions occur in your clinical sites, providers or MAs can alert interventionalists to see patients when providers are finished. If providers are running behind, interventionalists might be able to see patients before providers. Towards the end of their first SBIRT session, interventionalists can arrange with willing patients to follow up via telehealth. In initiating the first SBIRT session with an intervention, it's important that someone who has already known the patient make a warm handoff to the interventionalist. Here's an example of a warm handoff. The provider or medical assistant introduces Anna, the SBIRT interventionalist, to the patient. To enhance patient collaboration and trust, it's helpful to indicate that seeing Anna is part of routine care, and her services are intended to help patients stay healthy. Of course, we need to respect patients' autonomy and honor their decision whether they'd like to see Anna. If the provider or medical assistant needs to leave the room before Anna comes in, the provider or medical assistant can ask the patient if it's okay to send Anna into the exam room.
If you're already seeing the patient in a telehealth visit for another purpose, and you'd like to extend the telehealth visit so the patient can receive SBIRT from your interventionist, a similar warm handoff is recommended. This warm handoff is similar to the one done face-to-face, except that you ask the patient's permission before you admit the SBIRT interventionist into the telehealth visit.
If interventionalists will be outreaching to patients to try to engage them in SBIRT, they will be more successful if patients can be alerted in advance to the upcoming contact and introduced to the interventionalist. Introductions can be made by mailed flyers, emails, or automated phone calls. To maximize patient comfort and acceptance, it's best if introductions can seem warm and friendly. For example, in all introductions, you certainly want to mention the name of the interventionalist and say something nice about them. In mailed flyers and emails, it would be nice to include a photo of the interventionalist showing a friendly smile.
If your plan is to have PCPs do the first SBIRT session and have interventionists do follow-up sessions, then warm handoffs are recommended here as well. It's great if the interventionist and patient can meet and say hello toward the end of the initial session between the PCP and the patient. If that's not possible, the PCP can mention them by name, say some nice things about them, and perhaps show patients a photo of them, so patients feel more like they already know the interventionist a bit before meeting them.
Handoffs create vulnerability in care processes. If handoffs don't go well, patients may not be trusting and open to the new person. If telehealth handoffs don't go well, telehealth sessions might accidentally terminate. This is why it's critical to establish workflows for warm handoffs that specify when and how to do them, including scripts. For telehealth handoffs, there should be detailed instructions on how to bring a third person into the session and how the person who initiated the session can leave the session without accidentally terminating it. Finally, it's very helpful to have all staff practice and get feedback on warm handoffs before executing them with real patients.
Another important challenge to conducting SBIRT by telehealth involves administering questionnaires, which can feel tedious and pedantic if not done well. First, to elicit patient cooperation, let the patient know that you'd like to ask them a series of questions and explain why. For example, I'd like to ask you some questions about your drinking and drug use so I can help you stay as healthy as possible. I promise I won't judge you and I won't twist your arm to make any changes that you don't want to make. Would that be okay?
Once the patient agrees to answer your questions, it's best if you can show the questions on the screen. Have questionnaires available in multiple languages and ask patients which language they'd prefer, as well as what pronouns they'd like to use. Also, ask patients if they'd like you to read the questions out loud for them. We can't assume everyone's literacy levels, and we want to help patients feel confident and supported.
Many questionnaires have important time delimiters. For example, some questions on the audit ask about experiences with alcohol in the past year, while the PHQ-9 and GAD-7 ask about feelings over the past 2 weeks. To help patients give the most accurate responses possible, emphasize time delimiters when you get started and remind patients about them often as you proceed together through the questionnaire.
Let patients know if you'll be asking them the same questions in the future, and if so, give or send them a copy of the questionnaire so perhaps they can be ready with their responses before their follow-up sessions.
When you're ready to score the questionnaires, ask patients to give you some time for scoring. You might say something like, "Thanks for answering all those questions. Would you please excuse me for a minute while I add up your scores and then I'll come back and tell you what your responses mean, okay?"
Chances are that if you follow our previous recommendations, your telehealth visits will go well for patients and your staff. However, the only way to know for sure is to engage in plan, do, study, act cycles, known as Pdsa Cycles, in which you systematically gather information from your patients and staff and use that data to guide improvement.
According to the Center for Care Innovations of Oakland, California, here is a list of topics to consider getting feedback on from patients. The first 4 topics focus on technical aspects of their telehealth experience. The last 2 focus on overall quality and ways to improve the experience. Of course, it would be useful to gather feedback from your staff who are conducting telehealth visits. You can encourage spontaneous feedback face-to-face or by email, and you can solicit it more formally in one-on-one meetings or group discussions. Specifically, you might ask for their feedback on their ability to integrate SBIRT into their visits and ideas about changes that would improve your SBIRT program's impact.
Here's a questionnaire that the Center for Care Innovations offers for public use. Feel free to pause the video here if you want to take a longer look at this. This is the kind of data you'll want to collect regularly during improvement efforts and then periodically after to make sure there's been no slippage.
Beyond those questions, you might want to ask patients some additional questions on their introduction to their SBIRT interventionist, their ease of responding to questions on their drinking and drug use, and technical glitches. We've covered a lot, but if you're looking for more guidance, here are some very helpful resources.
Before we stop, let's summarize some key points. Experts expect that telehealth services will continue to expand rapidly. There's good reason to offer SBIRT by telehealth. Studies suggest that telehealth administered preventive counseling is effective.
Telehealth can engage patients in more initial and follow-up sessions, which would enhance the reach and effectiveness of SBIRT.
There are quite a few options to consider in deciding how you'll deliver SBIRT by telehealth. You could do initial sessions face-to-face with telehealth follow-up, add initial SBIRT sessions to telehealth visits for other purposes, or use telehealth for an SBIRT program that's completely separate from other services.
SBIRT could be delivered by PCPs or dedicated interventionists. Or perhaps PCPs could do initial SBIRT sessions and interventionists could conduct follow-up sessions.
When you plan to pass a patient from one staff person to another for SBIRT, it's critical to do warm handoffs or introductions. To maximize patient engagement and avoid technical glitches, it's best to have written workflows and scripts, and to make sure that staff can implement them faithfully.
It's also important to plan how you'll administer screening and assessment questionnaires so all goes smoothly and comfortably for patients.
To make sure telehealth SBIRT services are delivered with high quality, it's crucial to seek feedback from patients and staff and make improvements iteratively.
Here are the main sources of information we used to develop this presentation, which we hope you found useful.
Thanks very much for viewing this presentation. As always, please feel free to reach out to us with questions.